Where are you going? You are going over here. Okay, boom. Awesome. Okay, we are live. Lovely. Live on YouTube? Yes, we are. Guys, I'm going to kick off today's live session talking about why your back pain or your sciatica is getting worse. And I had a good comment on one of the TikTok posts. And the guy was saying, I'm doing the right stuff, but I don't know why it keeps getting worse. And one of the big things that is very difficult for people to overcome is the fact that when you have a back injury, as is distinct from when you've got an injury to your leg, there's nothing to stop you continually making this worse other than the pain, right? And so one of the great examples in this case was driving. Driving makes my back pain worse. Well, when you've got a boot on your right foot because you've just broken your ankle or sprained your ankle in a significant way, you can't drive. So driving is out of the equation for a period of time because it's not safe to do so. And the irony here is it's not that it's not necessarily safe for the foot, although that might be an issue as well. It's just not safe for you generally to drive. But in the case of the lower back, in this exact example, you will still continue to go driving in spite of that injury, in spite of what it's doing to here. So people say, well, my back hurts when I drive. And there's a reason for that. The reason is that we've got an injury. We've got maybe a disc bulge down at L5-S1. We've got a disc herniation at L4-5. Whatever it may be, there is an injury there. And when you sit down in the car specifically, you're putting more stress and strain on that lumbar spine, on that injured section of the lower back, and it is hurting. And there's no way to take that pain away fundamentally. Now there's quirks and hacks that we can do to make it easier on your lower back, to make it a little bit better. But fundamentally, when we are driving, we are putting more strain on the lower back. So if it's hurting, the smartest and most strategic way to get around these kind of things is you do these things that aggravate your lower back, that have no benefit to them, for durations below that aggravation threshold. So sorry, if you can't sit for longer than 10 minutes to do a car journey or in the office, you're going to have to limit that until you've made significant progress on the rehab. But if you do that well, then before you know it, you'll be able to start doing those things again. It's a very, very important paradigm shift. And that's why education is so important. I was going to read you out a comment, guys, because this was a really cool one that was posted on one of the YouTube videos. It said, honestly, before joining the program, I didn't understand what you meant by education. Now I know that education sometimes, in fact, maybe even often, is more important than the exercise itself. And one of the biggest things that frustrates me is when people go, oh, can you just give me one exercise for back pain? Can you give me one exercise for my herniated disc? Can you just give me one exercise for my sciatica? And there is no one exercise for anything. These kind of things are not going to get better if we're just looking for one quick exercise that we can do that's going to eliminate your pain tomorrow afternoon at 3 p.m. They don't exist. If we've got a back injury, we need to do the appropriate rehabilitation. And education, unfortunately or fortunately, is essential. We talk about this all the time, about the strategy for getting better if we've got herniated discs, if we've got sciatica, if we've got lower back injuries. And before I go through that, guys, if you've got any questions while you're live, I'm going to be going live for around about an hour. If you've got any questions, post them in the comments. If you're on YouTube, post them in the comments, and we'll go through them there. But we talk about this three-pronged strategy, and we demonstrate this within the program. There is a relief-based approach. Relief exercises for sciatica, for back pain, is something that, I'll keep that one there, is something that is necessary, is an ongoing thing, has no cumulative benefit. Movements like the towel decompression to take pressure off these little discs down there in the lower back, a fantastic one, but has no cumulative benefit. Movements like the bed decompression, correct form without rounding the lower back, hamstring stretching, contrast bathing, whether you're doing it with ice and heat or whether you're using something like the cube over here. Those are helpful tools, but they are of temporary value. That's relief work. We talk about this in the core relief section of the program. And then we have our strengthening work. This is the stuff that actually gets us better. That is the strengthening of the spine, learning how to strengthen the actual spine itself, starting out with technique, building on to find the appropriate intensity of the workouts to make them effective to change our body, and then doing that for the long term to eventually be actually strengthening the very discs that are injured themselves. But alongside those things, relief work, temporary. Rehab work, what we call phase 1, 2, 3, 4 in the program, strengthening, right? That's the stuff that fixes you. You must have an overarching theme of education. because there is so much opportunity every day for you guys to mess up your back. And with education, you start to see and understand why there is so much conflicting information around lower back pain, because people are working from different philosophies. People are thinking, okay, we're going to give people stuff to focus on the symptoms. And sometimes if you have understanding and education, you can understand and appreciate that a lot of those things are actually undermining the underlying problem, because they're not looking at providing solutions to the back injury. They are focused on the back pain. They're not looking at finding the solutions for the sciatic, the injury at the root cause of the sciatica. They're focused on the sciatic pain. And while there's no problem whatsoever with doing things that provide pain relief, they should not have unintended consequences of making the problem worse or going against the recovery process. And if we have education that goes alongside our rehabilitation, then we are going to be able to navigate around those pitfalls more effectively. I've got some comments coming in on YouTube here saying, thank you for the knowledge. What's your take on anti-inflammatory medication? In terms of anti-inflammatory meds, so you've got your ibuprofen and those sorts of things. One of the big problems with today's society, and there's a lot of good stuff about this. There's a lot of talk about inflammation, anti-inflammatory diet, anti-inflammation this, reduce inflammation that, get rid of inflammation. Inflammation is a normal and healthy part of a functioning human being. Out of control, chronic inflammation, system-wide inflammation, all that other kind of stuff, that's separate. Let's just put that over somewhere else for the moment, outside of the context of our lower back injury, and understand very, very, very acutely that inflammation is a process by which we're going to get the resources in place to go through the healing process, to get rid of cellular debris and all that other stuff, right? It's essential. However, in the same stroke, it's also a problem in this confined space, having out of control inflammation. I always use the example of my knee because it was relatively recent. I had like a golf ball size bulge coming out the front of my knee joint because there was so much inflammation in the knee joint itself because of the meniscus tears that I had. But in that scenario, there's lots of stretchy capsule to the knee joint. So although it's a little bit uncomfortable, it's not nearly enough to put pressure on that root of the sciatic nerve and give you that terrible pain. And so management of inflammation is something that we need to do strategically in the case of lower back injuries, so that we can minimize unnecessary suffering in a way that is not violating principles of a neutral spine and making the underlying problem worse. You can use tools like the cube, like just a pack of ice or frozen peas. They are free. You can use those to manage that inflammation. Medications wise, whenever you're taking a medication, it doesn't have the capacity, generally speaking, to be targeted to the area of the body. So you're not taking some anti-inflammatory pills that are going to target your L5-S1 segment. They're going to work everywhere. And then you have to deal with consequences of stomach inflammation and all that other kind of stuff. So you take another pill for that. Before you know, you're taking 16 pills to deal with 17 side effects, and you've got another one on the way. And so it's not really, I think, a strategic choice. And most of the time, patients say, I take the anti-inflammatories, but I don't really think they do too much. They don't really help me so much. If they help you, great, but try and get off them. Try and use, sincerely try and use some of the contrast bathing, icing strategies directly over the lumbar spine. If you use the ice here on your hip or your buttock instead of here on your spine, it will not do anything. It has to be over the target. And that's the whole point of using targeted inflammation management. And I think generally speaking, this is a much better strategy than just going system-wide. Not least of all because of the side effects or consequences that some of you might suffer more than others. And the last thing you want is to have stomach ache because of the anti-inflammatory pills you had for your back pain, and you're there sat on the toilet seat like this. Not going to be good. And people don't talk about those kind of consequences. Straining, stomach pain, all of that kind of stuff, not going to be helpful for the lumbar spine in ways that can completely blindside us, unfortunately. Mika's also said, what's your take on stomach laying? As I'm a student, it's difficult to seat and study. I lay on my stomach, have a lower back disc bulge and sciatica. The only thing to be careful of when we're lying down on our tummy, it's actually often quite a good position to contrast the incessant sitting that we do every single day. When you're on your tummy, you tend to have a little bit of lordosis support, which is quite nice. So the natural backward bending curve drops in. However, some of you guys with a certain kind of disc bulge in a certain kind of location and a certain amount of inflammation, particularly at L5-S1, so that's the last segment down here, you guys might find it a little bit uncomfortable. If you find it comfortable, awesome. Just be careful when you're getting out of that position because you can catch those joints at the base of the spine. It's not going to be a significant worsening of the objective tissue damage, but it might well hurt and feel uncomfortable, feel painful, and you want to avoid that as best you can. So in moderation, I would suggest, and don't be stuck there too long if you can, and get up carefully afterwards. Gate Weight has said, I don't have a disc bulge, but I experience sciatic pain. Is it related to the muscle? Nope, it's not going to be related to the muscle. You might not have a significant disc bulge, but it's always worthwhile having a look in a little bit more detail. Often there will be findings such as Normal age-related wear and tear. So then they said, well, you don't really have much of a disc bulge. One thing that's very clear from experience over the years is you can have an individual with objectively a very significant injury to the lumbar spine. I always talk about that case where we had the grade 4 spondylolisthesis, which is where the spine is literally falling off the pelvis, right? Terrible, very, very bad. And the guy had backache. Quite equally, and we've seen it many, many times, many more than that example, is the case of a minor disc injury, a strain, and we have objectively a very minor injury, but it is managed so poorly that we have significant muscle spasm, sciatic pain, etc. So assume it's an injury to the lower back discs, and great, it's a very minor one, that's fantastic, and then set about rebuilding the strength and stability and support of the lumbar spine. What else have we got here? Comments in TikTok. I'm suffering from a mild disc bulge, L4-3 and 5S1. What treatment can help me through? One of the important things you guys need to understand with treatments for your lower back injuries, this would be a classic one. And guys, most of you watching right now have the same injury, right? It's 4-5, 5S1. In this case, we've got 3-4 as well involved. It is basically the bottom section of the lumbar spine. Treatment is a part of the process, but it must be whatever treatment or therapy or intervention or injection or surgery you're going to have must be upon the foundation. It's the top part of the pyramid, the top 10%, right? Maybe less, maybe a little bit more, maybe depending, right? But it must be sat firmly atop a solid foundation in both education and rehabilitation. You can have a great treatment. You can go and have decompression in the other room, back there. You can have laser in the other room, as I was discussing on one of the TikTok comments earlier today. You could have any number of different treatments or therapies or interventions, but if you walk out of the clinic and have no understanding of how to look after your spine and have no strength and stability and support, you're just going to mess everything up. And you just spent money, time, effort, and energy, and someone's sincerely trying to help you, and you're sincerely trying to help yourself, and then we're tripping ourselves up on the way out of the clinic. We have to make sure that we marry a variety of different treatments, understand exactly what it is bringing to the table. So if we're doing something like decompression or laser, it's going to help optimize the healing process. It's going to take pressure off that disc. If we're doing something like acupuncture, perhaps, not that it's my specialty, and not that I particularly use it. No, I don't use it at all, but not that I particularly advocate for it. But it's doing something to relax the muscles off, perhaps. Right? Understand precisely what is actually happening to the and how that treatment is contributing to your recovery process, so that you're not put into having false expectations. Very, very important. Chris says, does the scarring on the disc as it rebuilds cause the disc to touch the nerve more? Basically, does the tingling get worse before it gets better? Fundamentally, there is actually quite a lot of space in the lumbar spine. So even in the scenario where we've got a reasonably strong disc bulge, the scar tissue is generally speaking not going to be in the way. Now, you might well do some sort of imaging to discover that it maybe is adhered, the nerve is adhered to those tissues, but I'd be suggestive that we're maybe clutching at straws in those sorts of scenarios, and rather looking for more problems than there are. Generally speaking, when we have the disc injury to the lower back, it's going to go through a scarring process just like everything else, right? We get a callus formation, and then those tissues remodel over time. Generally speaking, it's not going to be some crazy thing that's larger than the disc bulge itself. And by and large, we have the nerve might be being contacted. The nerves, when you look at them, you can actually see how small they are compared to the spinal space. You'll see those little grey lines on the MRIs. It's really the chorda equina. It's not actually the spinal cord. The spinal cord finishes up in the upper lumbar spine. It's actually just a collection of nerves as they go down and then exit at their various off-ramp, right? And so there's a ton of space. So it's highly improbable, not to say it's beyond the pale, but it's highly improbable that the nerve is actually being pinned up against the wall. What's more likely is that the nerve is just near the disc that's bulging, and there may or may not be some elements of scar tissue there. There probably will be if there's a disc injury. But equally, is most of the scarring going to be on some of those inner layers of the disc? We don't really know, and I wouldn't necessarily suggest perhaps the details of that are not necessarily able to be seen at the level of the average MRI, perhaps the full details of that. And so the most important thing to do, I would suggest, is just understand you've got a bad back. Make sure that when we're doing exercises, aggravation-free reps with correct choreography is what we're looking for, and move forwards with the rehab. That's the most important thing. ZZ has said, while squatting 2 months ago, I blew out an L5S1. Recovery is still going on. Back pain is also decreasing. But pulling feeling comes on some days and goes still I can't bend fully, like touch the toes. Your main focus after injuring your back should be rebuilding strength and stability in a neutral position. That means with the spine, with its neutral backward bending curve. That's what the focus should be for the foreseeable future, rebuilding strength and stability, and have a very, very close look at your technique to see where we might have been making some technical errors in terms of specifically the rounding of the lower back at the bottom of the squat. A very, very common mistake, and I would strongly suggest steering clear of the lower rep ranges. So focusing on reps of 10 is something that we talk a lot with our members about. Mac has said I have hip replacement, knee arthritis and sciatica all on the right leg. You just got to start on the rehab work, Mac. You've just got to start on the rehab work. You probably need a little bit more support to go through the process. There's going to be challenges, right? You're going to have to negotiate the hip replacement, any consequences of that, depending on how recent it was. You're going to have to negotiate the consequence of the arthritis, and you're going to have to negotiate that as you recover through, knowing that at certain periods in the recovery process, you're going to find the sciatica, or the back, let's say the back, because that's the origin of the sciatica, and let's say the leg muscles, so the hip and the knee respectively, right? Some of those are going to be challenged more at different parts of the process, and it's just a case of pumping the brakes a little bit on certain exercises and pushing the gas on others. For example, the hip hinge and the squat will allow you that interplay between those two to push on and improve both. But understand that most people, a significant number of people that have back issues, also have issues with the hips, also have issues with the knees, because the very things that have led to the degradation and vulnerability of the lower back are also structures that support good health in the knees and hips and ankles by extension. And so it's important to appreciate that actually that's Mac is in a remarkably common scenario. Okay, maybe the extension of the damage or the extent of the damage or degenerative change might well be greater than others, but equally it's probably better than others as well. And so all we can do is focus on doing the rehab and know that actually much of the rehab that you're doing, it's the back in shape program. That's our program, but you could very easily say it's a back in shape program. It's a hip in shape program. It's a knee in shape program. It's a lower extremity in shape program, because fundamentally you're doing exercises like the squats, hip hinges, the step ups. You're doing the single leg hip. Those are all leg building exercises. Why? Because the way in which we build a strong, healthy back is through a strong and healthy lower limb with a coordinated and strong midsection. And so we're not doing L5S1 disc exercises. We're doing, because you don't have the capacity to actually intervene at that level. No one does, apart from maybe your surgeon, who can go in there and cut this little bit on the left out. A very, very important point of distinction. What else have we got here? Miko, if you need more help, check out the program. We've got the full program. Check it out. We do tons of these lives, guys. If you need more help, we do a lot of lives. We've got tons of stuff on the YouTube channel. But if you do need more help, check out the program. Okay, just reading that one there. ZZ said, is a stretchy feeling in my leg and hip sciatica? It could be. It could be. It's very reasonable, given what you've just said, that you have a back injury. I think you've probably gone enough through the symptom side of things to know that it's the symptoms from one individual to the other are not important for your recovery process. The one thing that all of you guys need to have a very clear awareness of is the emergency symptoms, right? It's just an important part of the process, right? We've got the cauda equina syndrome, we've got the numbness, saddle anesthesia, we've got the loss of bladder and bowel control, we've got the significant trauma associated with our injury, right? We fell off out of a window or something like that. Thankfully, these things are incredibly rare. In the scenario that we don't have that, we have a very clear onset, right? We were doing squats, we went too far, we hurt our back, we've got an injury to the lower back, and then, okay, let's move forwards. Like we've got the diagnosis, a broad-based posterior foraminal disc bulge with left posterior central disc extrusion. You don't need to go any further, right? If you don't have the emergency symptoms, get working on the rehab. You can call it what you want. Fundamentally, the best way to name sciatica is to say, I have lumbogenic leg symptoms. Lumbogenic meaning the problem is here in the lower back, generated in the lumbar spine, and I have symptoms down in the leg. Now, as long as those symptoms aren't emergency symptoms, crack on with your rehab. That's the most important thing. That is the most important thing. And our rehab should be spine stability based work, and we should leverage that with some care of self stuff. It's very easy, unfortunately, especially if we're young or we like going to the gym, to want to do other stuff in the gym, right? Focus on your rehab, because if you focus on your rehab work and get better, you'll be able to go back to the gym and do all the other fun things as well. Other questions we've got in here on TikTok. So I do the towel decompression, but when I generally lie on the bed, I have a pillow underneath the knee. Is that okay? It's not ideal, Nero. It's not ideal to have the pillows under the knees, because what you're doing there, the reason that feels nice is because when you lie on your back and you lift your knees up, you flatten the lumbar spine. And when you flatten the lumbar spine, you open out these little holes at the back, but that has the process of stretching things out. And if we've got, as you do, if memory serves, a very flat lumbar spine, we're reinforcing that same process, which we want to try and mitigate as much as is possible, really as much as is possible. Got one on gait. I fell down on the basketball court, gait weight. I said I fell down on the basketball court. These days I have to sit 8 to 9 hours on a chair. It causes me sciatica. Doctor said it's because of the SI joint. I'd suggest instead it is because of the lumbar spine and gait weight. You need to do the work on the rehab front. You need to rebuild strength and stability. Do your best when you are at work having to sit down to try and manage what you're doing on a daily basis. Try and break up the sitting so you're not sitting for too long and you're sitting within aggravation-free tolerances. You're adjusting the position of your chair so that instead of having your thighs going like this, your thighs are sloping away from you a little bit more. That can help you keep a more neutral position. It's still not ideal. You've got a support for the lumbar spine, a little towel to support the lordosis, and potentially on the chair you can lean back a little bit like so, and this takes a bit of pressure off. You can see my arms are resting on the arms of the sofa, of the chair, sorry. And this takes the pressure off my lumbar spine. I've got less axial loading because when we are sitting down on the lower back or on our bum, on a chair, we are putting anywhere from 40 to 90% more load through the lumbar spine. So if we've got an injury to a load-bearing structure, that is going to aggravate that very conceivably. Now, there are some scenarios where you will find that sitting feels nicer, kind of like Neru's position where she's lying down with the feet, with the towel underneath, not the towel, the cushions underneath the knees, is that when you sit, for some of you guys, a lot of the symptoms are generated by the inflammation around the injured disc. And so the disc is starting to go through healing, but it's still got a lot of inflammation there. So you get a lot of congestion in these little holes where the nerves come out. So when you sit down, and you sit down badly, you see how big this little hole here gets, right? Because you're opening out the space. That's like a pressure release valve. That's why you so often get recommended knee hugs and child's pose and those sorts of exercises, because it feels nice in the moment because you're just making the hole larger, but at the cost of making the underlying problem worse, stretching out tissues that are trying to knit back together again. I haven't mentioned it in a while, but there was a little phase where you saw these, maybe some of you guys have seen it. You saw these little like plasters for cuts on social media, and it's basically 2 strips. You stick one strip here on one side of the cut, one strip here on the other side of the cut, and then you zip it up and it pulls the tissues together. You can see if you've ever had a cut on the surface of your skin that the tissues literally contract and pull each side together again, right? And then if you're doing your knee hugs to pull them back out multiple times a day, you can see how this has unintended consequences from a point of view of healing and recovery of stability to that section of the lower back down here. So very important to have an awareness of that, so that you're not making silly little mistakes that are stopping you getting better. What else have we got on TikTok over here? It'd be so much nicer if TikTok had a desktop so I could see these more easily, having to reach across. What have we got here? Kerala has had a L4-5 shallow, broad-based posterocentral disc bulge, annular fissure with mildly anterior thecal sac indentation, I suspect. The last bit was cut off, but thecal we finished with. I think sometimes you guys get caught up with the jargon, right? You've got a minor disc bulge that's touching some of the nerves, or the casing of the nerves, if you will. Might be an easiest way to understand it. And so we've got once we've got, like, I have the L4-5, like as soon as they mention L4-5, okay, we got an injury to the segment, L4-5. Okay, so it's not as healthy as it otherwise would, right? Would be. And some will disregard these sorts of things. Oh, well, it's maybe touching the anterior thecal sac, but it's not really compressing it. Great, you don't have symptoms. It's like, yeah, but I do have symptoms. We know we've got an injury there. We know we've got tissues that are identifiably less good than other tissues of the same type in the same person. And so we've got a smoking gun. So now sets about doing the work to stabilize and protect that little guy at L4-5 so that you stop moving and bending him into funny places. Because each time you reach for that kettle and you get that flare up, it's because you bent him off to one side or the other and you strained those tissues at the broad-based disc bulge. And understand very clearly that although it might not be mentioned in many cases, the annular damage, so the annular tearing, annular fissure, well, is par for the course, right? This is the disc. We've got a nucleus in the middle, contained effectively by the annulus fibrosus layers of ligamentous tissue. If that disc material is out here, not that it changes color, but it's out here, by definition, the annulus must have been damaged in some way, shape, or form, even if it's not explicitly mentioned. It is compromised, it has lost its integrity. That is obvious, right? And so We don't need to get distracted. Is it an hernia fissure? Is it a disc bulge? It's the same fundamental complex. It's like I said the other week, it's like describing like a criminal. Say you saw someone do something naughty and you say, oh, I saw him. He had a blue hat and he had a beard and he had a red coat. That's not three separate things. It's three comments on one thing, right? And so we've got those three comments on this one thing, and there might well be some other commentary on the facet joints which would fit the same description of the same thing going on, and then you just rehab for that injury at the level of the lumbar spine, because you guys can't be specific to L4-5. You can't do anything to L4-5. You can do something to the lumbar spine, you can protect the lumbar spine, you can engage and support the lumbar spine, but you cannot engage and support L4-5 specifically. Like I can hold my elbow at 90 degrees and then I can bend my wrist one way or the other without my elbow bending, or I can move my shoulder without my elbow joint or my wrist joint. You can't do that with your lumbar spine because we're not wired to be able to do that. And that's something that is lost on a lot of people because it's never spoken about, which is going back to the start of today's live. That's why education is so important, so you understand the why certain things are said. That's why there's not specific exercises for an L4-5 disc prolapse on the left-hand side. We've got user 972, which has exactly the same issue, although there's different nuanced detail. But the nuanced detail is quite irrelevant to the rehab that you guys are going to do. So we've got an L4-5 prolapse. We're struggling to sleep at night on a firm mattress. What kind of topper do you recommend? I don't recommend buying anything at night. I don't recommend buying anything when you've got back pain. Unless, of course, your mattress is shot to pieces and it's 15 years old and it's bowing in the middle. Of course, get a new mattress, right? But the problem is, sleep is really important. It's when we recover. And a lack of sleep is seriously bad for our health and well-being on a number of different levels, not even in relationship to the lumbar spine. So when our sleep is disturbed because of our back pain, we immediately get focused and say, what can I do to fix my sleep? You can fix your sleep by fixing your back in the day. People are too worried about how they spend the unconscious time, and while they're not doing anywhere near enough effort and energy to actually fix the time where we are conscious and awake and able to actually change something. So focus instead on getting the day right, doing your rehab exercises, doing your rehabilitation work, thinking about what you're doing before you go to bed. Too many people will finish dinner and then they're going to sit down or relax or do nothing fundamentally, or quote unquote nothing, right? For 2 or 3 hours before they go to bed, inflammation is building up in these little spaces where the nerves come out. Then they try and get comfortable, and within a few hours, if not less, they're all of a sudden in pain when they roll over. And that's because you've started the clock on this area filling with inflammation, these little holes filling with inflammation at 7, 8 p.m. after you've had dinner, rather than doing a little bit of stuff before we go to bed to get things moving and drain some of that excess inflammation. This is why things like your relief-based work, your care of self-based work that we talk about in the program, the core relief work, is so important that you leverage that alongside your rehab stuff, because that's little tools to help offset the stress and strain of daily life that you do multiple times a day. And guys, just since I haven't mentioned it at the start of the live, if you guys need any more help and actually want structure, if you've been struggling, we've got L4-5 disc prolapse, we've got a L5-S1 herniation, which I'll touch on in a second, right? If you need more help and structure, an actual rehab program, not just a sheet of exercises, go and check out, on TikTok, go and check out the link in the profile page. On YouTube, guys, I don't know if it'll paste. Oh, there we go, yeah. I've pasted it into the chat. Go and check out the video there after the live stream and have a look. Start the program. There's lots of information there. We've just rolled out a ton of really exciting updates that'll help give you guys the actual structure to get better, and more importantly, the education alongside that. Sonia said, I have an L5-S1 herniation and severe canal stenosis and have been in pain for 2 months. Go and check out the stuff there, right? There's 3 parts to the program fundamentally. There's the core relief work, which is stuff that takes pressure off that L5-S1 disc bulge down the bottom here, the herniation. There's the strengthening work, which is actually going to rebuild strength and stability to the lower back. And then there's the education. Because so often people will maybe even start doing the right stuff, but then they completely undermine that work by the way in which they're using their body every single day. So you need to understand that one of the reasons that you're doing the specific exercises that you're doing, and for those of you that haven't heard it before, the core 5 we talk about, the dead bug, the marching bridge, the squat, the hip hinge and step, but the reason you start those immediately is because you are doing those movements every single day anyway. At least if you start learning how to do them correctly, you're going to start to make those actions daily safer. Sandwich truck time. You're going to start to make them safer, right? You're getting up out of bed in the morning, you're doing a squat. Learn how to do it safely. And actually having because sometimes people say, oh, I'm doing the squats. Why am I doing the squats? Because in the early stages of recovery, just by learning how to do those squats more effectively, the many, many tens, if not hundreds of times you're getting up and down out of chairs, on off the bed, toilet seat, whatever, every day will be done safer. And therefore you've managed to mitigate something that was unwittingly aggravating your L5-S1 herniation every single day. There are multiple purposes to the exercises. If we're talking about exercises that have been thought out and structured, there's purposes behind them at different stages of the process. And very early on, the purpose of the exercise is that they are representative, emblematic of movements you're already doing every single day so that you can make yourself safer. And that's why a lot of people will notice they start feeling better very, very quickly. In a matter of days, they start to realize, I'm starting to feel better. Why? Not because you've made any improvement in terms of any significant improvement in terms of healing. You've just stopped aggravating things every day. So many of you, I don't know why. It's like, I don't know why my back pain keeps flaring up. It's like, you've got a toddler and a baby. It's like, what do you mean you don't know why your back pain keeps flaring up? Like, you're constantly looking after children. You've got a dog that you walk every morning. What do you mean you don't understand why your back pain's flaring up? You're doing so many different things every day that are small little things on their own might not be a problem. But there's so many of them that they're constantly aggravating and irritating that recovery process. And make no mistake, these discs do heal, but they heal very slowly. And so many of you are constantly re-injuring upon re-injuring upon re-injuring without ever giving them time to go through an appropriate healing process, which does take time. Owen has said on here, so I can catch a breath, is there a possibility of recovery from a herniated disc after delaying doing the exercises? I delayed thinking it was minor until I got my diagnosis of MRI. Owen, that's more or less everyone that's joined the program. Like we basically have, over the years, in clinical practice, because we've done more high-end treatments, people are very reluctant. People will often, okay, so this is a typical scenario, right? You injure your back. First of all, you leave it for ages. This is basically everyone, by the way, Owen. It's not just you. It is everyone, so don't feel dismayed. You leave it for a while, try and ignore it, and then you end up going to the GP. The GP says it should get better on its own in a couple of weeks, a couple of months. The GP is the doctor, for those of you in other countries of the world. And they say it should get better on its own in a couple of weeks, a couple of months, but here's some pain medication, come back later. Then you get told to go to some physio because it didn't work. And you say, can I have an MRI? Can I have an imaging? They go, no, well, we'll schedule it in. But here in the NHS, it's 6 months to a year, maybe longer. And then you end up having the MRI and you go, oh, it's a disc bulge. And then you try some other things. Maybe you go see an osteopath, chiro, physio, etc. And then you go and see something like our stuff. Right? Many of you guys have had the problem for a long period of time. You've had back pain, back injuries on and off, and you've always tried to manage it with the physio or chiro or whatever else, but you're never really doing anything other than going from one flare-up to the next. And so that's the scenario that most of the members, of the thousands of members and patients I've ever seen, are in. They don't come to us the first 3 days that they injure their back. They come to us much, much later, and they can still heal. They can still get better. They can still recover. They can still go back to doing all they want. So hopefully take that as a positive note, Owen. You've probably been leaving it a lot less time than many others, but equally, it would have been better if we'd have started sooner, right? I think it's a Chinese proverb. I might be wrong here, but it says the best time to plant a tree was 20 years ago. The second best time is today. Don't dismay that you haven't done stuff so far, or you could have done stuff earlier. Just start doing stuff now. That's the best way forwards. So Curla said I started a few weeks ago doing a 5 core. Awesome. Get started. If you need more help and guidance, right, check out the program. What can you say about static lumbar traction? Straight traction, Jeff, I would say is not so great. But if you're pumping it, pulsing it, like we do on the decompression table, or like you do with the bed decompression, those are a little bit nicer, or a lot nicer actually. Any advice for someone dealing with L3-4 disc herniation on top of combo scoliosis? Exactly the same stuff. Right? It doesn't change. If you've got the scoliosis going off to one side or the other, that's going to mean that you're likely to have symptoms on one side versus the other. You've got other factors, but it doesn't mean you don't need to be able to squat. It doesn't mean you don't need to be able to hip hinge. It doesn't mean you don't need to be able to do some of those asymmetrical exercises. You will often notice that you have significantly more asymmetries than maybe someone else because of the scoliosis, but all you can do is get stronger and stronger. Having family members that have quite significant scolioses, as I've discussed on some of the lives before, like I know about this, and there's not really much else you can do other than get stronger. You've got innate or you've got circumstantial difficulties that are a bit more challenging than someone else, but what's the other option? Do the rehab work and know that there will be that asymmetry that you're going to have to manage along the way. As long as you do that well, you're going to do well. Senna said, what hip mobility exercises are effective for that rounding the lower back? all hip mobility exercises. And this is a big misconception, right? I'm not sure if you're asking what manner in which that question is being asked and what background information there is, because there's limitation on the word count here. So I appreciate we can't necessarily get context there, but you don't need to do a hamstring stretch like this. Hip mobility should not involve the lumbar spine. Do you know why? Should hip mobility involve your shoulder joint? No. Why? Because they're different joints. So if you want to do shoulder mobility, go and do shoulder mobility. If you want to do hip mobility, do hip mobility. Hip mobility does not need to involve your lumbar spine. When you do this on a hamstring stretch, for example, all you're doing is wasting time with your lower back. The hip joint is the thing that needs to take you through flexion with a relatively straight knee, and then you will stretch the hamstring. The lumbar spine has no business being involved in the lower back. Now, do we round our lower back? Do we involve our lower back when we do some of these stretches? Yes, but we do it to the detriment of the effectiveness of the stretch for a number of different reasons. But when we've got a lower back injury, we really need to be precise with this, and we need to not involve the lumbar spine. But also, as I suspect in a lot of the cases when you guys ask about hip mobility work, focus on your spine. Don't worry about the hip mobility, because if you have an injury, let's just say your hip mobility is limited on the left-hand side because you've got sciatica and an L5-S1 disc bulge down here, and your hip mobility on that side is limited. You're going to do some lovely stretches, some lovely mobility work, assuming with a neutral spine, because if you're not, that's a problem, right? And then you're going to free up your hip. Oh gosh, my hip's feeling so much better now. Great. And then you go and reach for the kettle and your back flares up again, and you get signals going straight back to those muscles to tell them to tighten up. This is why mobility work, stretching work, all of that kind of stuff is very, very pointless in the early stages. It's not completely pointless. We include some element of that work done in the relief-based work, but you are under no illusions that it is temporary in its effectiveness and it is not fixing you. That's very, very clear. It is the rehabilitation work that fixes you, that makes you safer. And the nice thing is, as you progress with the strengthening work and you actually build resilience in the lower back and it goes through healing, you stop the signals that are going out to those hips. So when you do your hip mobility work, it actually works, and then it can be cumulative. Because the cause of the stiffness, although there might have been some existing stiffnesses as a result of the ways in which you've used your body over the years, the cause of the notable stiffness is signals going to those muscles telling them to tighten up, because you have an injury in your lower back that is creating inflammation that is irritating those nerves. So it will perpetuate that process until you fix the lower back. Hopefully that makes sense. MRI report says straightening back with loss of lumbar lordosis. Is the towel decompression suitable? Think about it, right? This is why education is so important. Of course, the towel decompression is vital. The towel decompression is there as an essential in the program, because what Curler has just written is more likely to be the case than not for a lot of people with long-standing lower back pain. Why? Well, it's nothing special. Most of us spend a significant amount of time sitting down every day. And if you're spending that time sitting down every day, your body adapts to how you use it. It adapts and degrades, but also many people, if you've got a lot, and this is just from experience, most practitioners do not have the experience of working with patients and images. They work with patients, so they never see the images because they don't routinely work with them, because they're too busy telling you that you don't need images for your lower back. And that's not to say you do to treat them, but you should. But I'm very lucky to have had the experience that I've had so closely with imaging to make you a bit more humble about what you can tell from a physical exam, what you can't. And one of the things that you know over time, having done this, is that it's very likely that those with long-standing lower back issues are probably, if they've got any abnormalities at all, which is not a foregone conclusion, in the alignment of the lumbar spine, it's more likely that it's flattened than too much curve, because of how we use our body on a daily basis. And this is one of the reasons the towel is there, because so much of what you're doing every day is flattening you out. And so the towel is an antidote to that. It is supporting the natural lordosis. It is taking the pressure off the discs. It is also taking pressure off the ligaments on the back and the muscles on the back that are stretched every day, which is why they feel tight, by the way, which is why you don't need to stretch them more. They're tight because they're being stretched and pulled apart all day. You actually need to take them off stretch rather than stretch them even more with knee hugs and child's pose and the like. Hopefully that makes sense, and thank you for a very good comment and sharing that MRI, because it helps me talk about that stuff which is so relevant to so many people. For degenerative discs, what can I do? Everything I've just been mentioning. Hopefully that helps. Louisa, I have been told I can't have any more injections. You've got to understand what's going on, right? Like the injections are doing nothing for the injuries. If you've got degenerate tissues, those are tissues that are not healthy. They're not healthy at all. And so rebuilding the strength and resilience of those tissues is of vital importance. What can you say about lumbar traction? We've already done that one. Any advice for someone dealing with an L3-4 disc bulge? Done that one as well. Guys, if you guys have any more questions, please do post them in the comment. Oh, as if I'm cue. Sunil. I'm going to keep going. We've got around about 20 minutes left, guys. I will keep going on the live Q&A. If you guys have any questions, post them in the comments. We'll go through them. And of course, if you need any more help and more structure, then check out the link in the profile page. And guys, the link in the chat on YouTube. So Sunil has said, I have an L4-5 disc herniation, which was under control. Recently, I've started feeling radiating pain. Is the sciatica flare or flare-up of an old problem? The sciatica would be generated from an L4-5 injury, and that would be perfectly reasonable. Under control, I don't know what under control means. So many people will get their back under control and then carry on. It's like, I don't know what under control means. It might be that you just do constant knee hugs all the time to manage the pain. We should be doing proper rehabilitative work to rebuild the strength and resilience of that section of the lumbar spine. It is very reasonable to suggest if we've not done that and haven't built to a verifiable level. For example, if you've done the right sort of stuff, Sunny will be able to say, yeah, I'm up to 70 kilos on a squat, which represents 80% of my body weight, for example, for 10 reps without aggravation at all during those exercises. And I'm able to do a couple of other things, right? So that might be an example that Sunil has done a good job with rehabilitation, and then he's had a flare-up. And he'd be able to say, I had a flare-up doing X. In this sort of scenario, it's kind of maybe just started to come back on, probably because we're not doing the rehab. We're not doing, well, we might be doing rehab, but we're not doing actual rehab for the lumbar spine. We're doing, as is all too often the case, a bunch of exercises that my last physio or osteo or chiro gave me, and it's a couple of different things that I do, and I do it a couple of times a day. That is not a rehabilitation program. You can't call that seriously rehabilitation. Under control means pain-free doing exercises to keep the back strong. I don't know what strong means, and I don't know what exercises are, right? And I don't mean that to be mean, Sunil. I mean that to say, if they could be anything, and because they can be anything, I don't know what they are, right? And I appreciate this is a live session. You just jumped in, you posed a question. Hopefully some of this has helped you think about those things. I've touched on a few things. Hopefully it's helped you think about some of those things. If you're partway through the process and we haven't built good degrees of strength, then it's very reasonable that you've had a flare-up, and that would be perfectly reasonable symptoms to have associated with an injury at that level of the lumbar spine. And the one thing that's really important to remember, guys, is that all we can do with our rehabilitation, all we can do before we ever have an injury, is decrease the likelihood of us having some kind of event that strains our body to a point at which it can't handle. That's all any of us can do. No one can never have back pain again, just like you can never not have a cold again. But if you look after your immune system, your body, your health, you have good body weight, you stay active, you've got good fitness, etc., you can build a system that is resilient to stress and strain, infection, disease, and all the other sorts of things. But you can still get caught out, right? You can still trip over and fall and bang and break your arm. That could still happen. But if you're frail and not able to move and can't do certain things, then the likelihood of that happening and the severe consequence of that is higher. And so that's all we can do. So it could be that Sunil's actually done a really, really good job, but he's just got a bit of bad luck. That could be the case. And this is why having support along the process is really, really important. As you're going through the rehab work, as you're building strength and resilience, that we're having a look at some of those things. Other questions. P.S. What's the first part of this question? I've just had my MSK appointment and they've told an MRI, I'm super stiff, no movement in the lower back. I can't do a cat-cow, it's just too stiff. I'm 45, fit and strong, just can't bend my lower back. You don't need to bend your lower back. If you've got an injury to your lumbar spine, you don't want to be bending and rounding the lumbar spine. It might well actually be stuck. One of the really interesting things, people often think, oh, I need to do more bending, more twisting. Focus on calming down the lower back inflammation and doing strength and stability work. Fit and strong means a whole host of different things to different people. Specifics, I squat this much without aggravation, without rounding my lower back. Some of the fit and strong people might well be doing good squats, but then they've injured their lower back, and now that butt winking that they've been doing, whenever they squat, they always do that, and they do it with a rounded lower back, right? They squat like that. Okay, now that doesn't work because you have a compromise. So there's a whole host of different things. But you don't, if you've got an injury, it's like saying, I've got a really sore ankle because I went over on my ankle and it bent to the side like so, right? I bent my ankle to the side and it's really stiff and I can't move it much. So what I'm going to do is I'm going to keep trying to bend it over and over again because that's really going to fix the problem. That's basically what we're doing with the cat-cow. No, stop. Provide stability to the area. You leverage some relief-based strategies to calm it down a little bit. Make sure that we are actually as good as we thought we were in terms of the strength and stability work. Making sure that the squats are aggravation free. If the squats are not aggravation free, then there's something to look at there, right? having a look to see if we've got appropriate levels of hamstring flexibility, of hip flexibility. One of the things that we've shared with our members, which is we're just lucky because people post their x-rays and images, we've got a number of members over the years that have had flexion extension x-rays. One of the things that you often see, and I wouldn't be surprised if it was in this case, it might not be, but I wouldn't be surprised, is the person, when they stand up, you should have a smooth backward bending curve. This is called the lordosis, right? This is the bum here, right? Tummy's over here, lumbar curve. The person has bad back pain, and I wouldn't be surprised if this was scenario, and they're stuck like that, which means their back is already stuck flexed when they are standing up. And when this person has a flexion extension x-ray, which means they get a photo taken bending forwards and they get a photo taken bending backwards, their back is so stuck in flexion that when they bend forwards, they make it more bending forwards. And when they bend backwards, they can't even get back to neutral. So you think the reason you can't bend any further forwards is because your spine is already bent forwards, but you're standing upright. That could be the scenario, right? That actually your spine is already flexed enough. Your lumbar spine is already flexed, but you're standing upright. You don't even know this if you've had imaging. So we don't know that you necessarily need to be doing more bending forwards. I think literally, I don't know if it was today, someone posted on here saying I had an MRI and my lumbar spine was flat. My lumbar spine was flat, which means that your lumbar spine, when you are standing upright, is already bent forwards. So you don't need to do more forward bending. You don't need it. If your lumbar spine reorientates it into an extended or neutral position, then when you bend it back to that same degree of flexion, it will all of a sudden actually be bending forwards. But if everything is so straight and flat that when you're standing up, you're like that, you don't have any more forward bending to give. Whereas if you're like that, now I can forward bend. You see the difference, right? If your neutral position is actually in the neutral, when you bend forwards at the lumbar spine, you actually bend forwards. If you're stuck like that and you're stood upright, you don't have any more forward bending to give. So something to think about there. Hopefully that helps. Just straighten that spine back up again. Leo has said, thoughts on the McGill Big Three? I think they're all right. I think the big problem is, like, I've seen Stuart McGill explain, for example, that I think it's called the curl down or something like that, where you put your hand behind your back. Number one, why hasn't he thought to just use a towel? This is a very, very, prominent figure in the back pain space. And I think a lot of his stuff, we align very closely with a lot of McGill's stuff. But I think the big three are missing loading. I'm not a big fan of the side plank, just doing holds. I think putting this arm behind your back doesn't make sense, not least of all because this end of the arm is thicker than this one, so now you're going to put a rotation, plus if you don't have enough shoulder mobility, it doesn't make sense. Additionally, I've seen other people talk about his stuff, which when he talks about it, he says the purpose of that arm there is to provide support for the lordosis, but maybe wonky support, which means why not use a towel? Everybody's got a towel, it's free, right? So that to me is like, why didn't we think of that? And additionally, when I've seen other people talk about McGill Big Three, they teach people to do flattening the back to the ground. And so I think there's a drop off, and as is always going to be the case, right? He's got the knowledge up here, and then when people learn, they miss certain things that are actually very, very important, such as the support of the towel or the support of the natural lordosis when doing some of those exercises. But I think they're just incomplete, personally. I think you need to have load bearing. But then if you listen to him talk in its entirety, when he's talking about things, he talks about rebuilding load tolerance anyway. So I think that's not a fair, that's like saying, what do you think of an incomplete, what do you think of Stuart McGill's incomplete rehab program versus what do you think of his complete rehab program? Because the McGill Big Three, I'm sure, is not his complete rehabilitation program, right? He's got a full, and I think a lot of the stuff that he talks about is reasonably in alignment with what we talk about, or what we talk about is reasonably in alignment with what he is talking about. Thank you for great, thanks Esther, appreciate that. Hello, residual lumbar pain after L4-5, 3 mil disc bulging. The disc doesn't get back into place. Most of the time, your disc, say we've got a herniation or a bulge like this, this is going to heal in this position. It's going to create scar tissue in that position. Then slowly over time, that scar tissue is going to remodel. In some cases of the more minor strains, it might well go to the point where it goes back to where it should be. But it's not like just popping back in like some sort of piece of Jenga or something like that. Focus on your rehab. This is Fabio. Focus on your rehab. Rebuild strength and resilience into the lower back, and you will get better, or your symptoms will go away. And then you'll rebuild resilience. And you'll have like one of the reasons that you're doing things like the squats and the hip hinges for your lower back recovery is because you have an explicit understanding. I know that like 6 weeks ago, I could only pick up the 5 kilos and do a squat because when I picked up the 7.5, it really hurt. And I know now I can pick up the 80-pound kettlebell and I can do a nice squat and not have any pain for 10 reps, right? You know objectively, very, very clearly that you haven't bypassed the load, right? You haven't built in like a route around. That load was going through my spine, my herniated disc at L5S1, for example. Right? And that herniated disc didn't used to be able to bear that load, and now it can. That is why the exercises are so helpful, because you now know that I can bear 80 pounds of load in a neutral position. Then I can start looking at other things I can perhaps do, other things I might be okay to get back into, etc., etc., etc. I want to carry my golf clubs. Well, maybe actually my golf bag is about 30 pounds or 20 pounds or whatever it may be, right? If you're carrying enough balls like I do, then it might be heavier, okay? So maybe I'll get a golf buggy when I go to golf, when I start getting back into it. But I know I can bear 80 pounds of load because I've built it back up. So it's reasonably safe for me to assume that I could go and do X, Y, and Z. That's the additional benefit of your rehabilitation. If you're just lying on the floor, hugging your knees and hoping for the best, that gives you no usable information to know how healed or how strong or how resilient or how capable your lower back is. Comments here, I'll just put my hand there so I can actually see. The back pain relief routine, 5 core exercises, enough to do it once a day. What I would strongly suggest, if you are serious about getting better with your back pain, go and check out the program. But the relief work is very distinctive from strengthening work, and how you do strengthening work over time changes dramatically. Your strengthening work is your rehab. That's the stuff that gets you better, make no mistake. Relief work is stuff like the bed decompression, tower decompression, contrast bathing, all of those kind of things. You can do those multiple times a day. We've got routines in the program that take 8 to 15 minutes. You can do those multiple times a day, nice and easy, right? Really great stuff, and you should do. The strengthening work varies tremendously. So when members start out with the program, when you guys are starting out doing your rehab, you might do each of the exercises multiple times a day because you're learning how to do them. You don't know how to do them. You need to practice, okay? But then as you put them into routines, like the full routines that we have in the program, you're then going to start doing them daily, once a day, only once a day, okay? Because there's no point doing strengthening work multiple times a day. You're just going to overtrain, right? And then over time, as the workouts increase in their vigor, in their intensity, as you make progress, you drive progress, you're going to maybe do 4 or 5 days a week. And then maybe later still, you're going to then, this is what we talk about in the phase 4 of the program, adding in additional workouts, working on other areas, right? You might only do 1 or 2 hard sessions a week of spinal loading and strength building. And then the other days you're doing other stuff. Like, it varies as you go through the program, which is why, going back to that sheet, unfortunately I am bashing that sheet a little bit today. That sheet of exercises you get given is not rehab. That is just a random list of stuff to do. And quite frankly, stuff to waste your time with. Nirvana said, I don't do axial loading in the gym for 6 months. I have squatting with a battle squat and RDL with a barbell, but nothing close to my strength, which I have no issues with. I assume it's just time until I add axial loading over time and progress loading over Christmas. There is no time on these things. The important thing to understand is it's not about just allowing an arbitrary amount of time to pass. Everybody is going through these processes at different paces. So that's why you make, all you're doing with your rehab is you're getting a point of safety, right? Body weight, for example. And then you are steadily moving forwards. I think the belt squat is a bad idea. All you're doing with a belt squat is building greater disparity between what your legs can bear, strengthening your legs, and what your spine can bear. So I'd say the belt squat is actually a bad idea. Not because it's making you worse, but it's making the disparity that you're going to have to deal with much harder to deal with. People that train already, and I can see from the profile pic, we're doing some kind of fitness work, right? People that train already have a hard enough time getting back into back rehab without messing themselves up because they've got muscle memory. You don't need to make that muscle memory even more of a problem because you're smashing legs by circumnavigating the back. I think it's unwise in the short to medium term. What is much smarter is getting back into the squat. A great option for the squat, we talk about it all the time, is a low hold dumbbell squat because it allows you to keep more upright, like so. You can steadily go up the squat, up the dumbbells over time. We talk about this in phase 3 of the program, using discovery workouts to find what is your current limit so you can make it effective. Allowing just 6 months or 17.5 days or 21.5 weeks to go by before you add loading is not strategic. It's just random time. Whereas if you're carefully going about your loading, you can figure out today what the appropriate amount of loading is. Because make no mistake, Nirav, you're going to be putting some element of loading on your spine on a daily basis. Today, tomorrow, yesterday, the day after, right? You're going to be doing that. And at the moment, you don't know whether you're capable of that or not. So you may as well start doing some element of objective work. And I understand it's actually quite nerve-wracking, which is why we have the program with the support, because it helps guide you guys and you've got people to lean on. You say, hey, Mike, I'm thinking of doing 15 kilos on my squat. Okay, well, what did you do last week? Oh, I did body weight. Okay, well, why don't you just try with a 5 kilo and do a couple of 5, 10, 15 kilos, or maybe something else, right? It varies from one individual to the next where you're going to start. But start ultra conservative and then swiftly move up as you build confidence. And then you'll start to get to a point where you slow down the pace of moving up. And you're like, okay, is 25 okay? Maybe I should go 26, maybe 27 and a half. And, okay, 28 is too much. Okay, we're going to stick here and then go. Can stress make back pain more painful? It certainly can. It's certainly not going to be helpful to have cortisol running through your system all the time. That's definitely a problem, right? Definitely can be a factor. But how you use your body when you're stressed. What are we doing when we're stressed? We're generally not positive. We're generally going to be small, curled up, this sort of thing. You know, all the kind of stuff that's even just mechanically, the stressful positions, the postures that we adopt when we are stressed are not going to be ideal for the lower back, let alone other bits and pieces. Can I get back to gym and do some core work? Lifting weights will make it worse. Wrong, Fabio. And what are we going to do by core work? We're going to do some abs, some crunches, something like that? No. Like you going to the gym is going to involve you doing movements like a squat, like a hip hinge, like a step up. This gym has a couple of stairs and you're going to go up the step up. You should start with body weight. Yes, we're not saying go to the gym and start picking up the 80-pound kettlebell. We're saying go to the gym and do body weight. Maybe use some of the equipment there. The fact that they've got 1 to 10 kilos, you can go and play around with those. I think in those sorts of scenarios, like definitely getting some more guidance and support would be really helpful. But the thing is, the 1 to 2 kilo kettlebells that are in the gym are probably lighter than the kettle, or lighter than the rucksack that you're going to take to the gym, or maybe lighter than the water bottle you're going to carry into the gym, right? It's not about making this sound scary, you know, doing weights, right? Not lifting weights sounds scary. You carried your phone into the gym, your phone weighed something, right? In the microphone case, the phone's up here, right? It's figuring out what weight. Don't make it sound scary about lifting weights. You're doing rehab. That's why we call it rehab, right? And you're just carefully finding the right amount of load. That is core work. A squat involves your core. If you do not squat correctly with your core engaged and involved, you will not do it. You will aggravate your back. So learning how to do that is so important. Leo has said, thoughts on hyperextensions. I'm not a big fan of hyperextensions because the main focus in the short to medium term is the neutral lumbar spine. And so hyperextension, just like forward bending, is moving away from that. I don't think it's appropriate. Do you want to get back into hyperextensions in the future? Sure, go ahead. But I would suggest that they are beyond back rehab rather than back rehab. Nirav said, I tried 5 kilos for 2 weeks and after I was in trouble, so I stopped the back squats. On top of this, I have issues with my neck and mid-back, so hard to know when to axial load. 5 kilos, I don't know what we were using for 5 kilos. Was that 5 kilos on top of the bar, which would be 30 kilos? As I mentioned, start with 5 kilos in your hand, doing a low hold dumbbell. That's a good starting point, right? And then go from there. Obviously, if we've got other issues, then you've got to try and manage those issues at the same time. And it's difficult to do that sometimes on your own. So having a bit more support can make a difference. But you've just got to adjust to find the right weight for you. That's your work. That's your job. Your job in the early stages of rehab is to get the technique, find the technique that you can do effectively, and then find the right intensity. And then we push on from there. Any advice for my exercises? Squat, hip hinge. How do you know how to use the correct weight? The only way you know how to use the correct weight is to test out the correct weight. Yeah, Nirav said barbell plus 5 kilos. So you're starting too high. We always suggest starting your rehab with the dumbbells, dumbbell low hold. Leave the barbell alone. Start with the dumbbell. Admittedly, the barbell might have been fine, right? But evidently, we're not quite doing something right. Maybe actually we're not as good as the barbell squats as we thought we were. A lot of people aren't. I say to a lot of the guys anyway, and ladies as well, I say the best thing to do is to start out using the dumbbells. And once you get to about 30 to 40 kilos, your hands start to become the limiting factor in holding the dumbbell or the kettlebell. I mean, that's 80 pounds. That one's 36 kilos, I think it is. No, yeah, 36 kilos. Like, you can still do 10 reps on that. And that's way more ergonomic than using the barbell. So I'd suggest using that to start with. It work a lot better, and then transition over to the bar. Any good tips for an antalgic disc bulge? Antalgic lean, disc bulge is reduced. Just steadily work on the rehab and the antalgic lean will go as you, because the antalgic lean is avoiding pain, avoiding the side. And so as you make progress, you don't need to avoid the side anymore. The biggest mistake people make is focusing on trying to game the antalgic lean, the leaning off to the one side and trying to fix that rather than just fixing the back, and then the lean takes care of itself. My MRI report says it's bilateral. I got to check I'm not a robot again on TikTok. Every time as I cross the hour, I suppose it serves as a good reminder. Guys, we're getting towards the end. Yeah, Kurt, I'm not surprised that it mentions the facet joint as well. It's very common, guys. You have to remember, the facet joint isn't like existing over here and the disc over here. They are part of the same bone, right? So if something's squashing down here and it's squashing, this is a spacer. The disc is a spacer that keeps the facet joints apart. So if there's going to be issues here, I know I talk a lot about discs, but I also mentioned this many times before as well. It's a segment. You guys injure a segment. And arguably, the best level of analysis for you to work on your back is that you have a lumbopelvic problem. You have a problem in this area. That's probably the most detailed you need specifically, because that's all you can do. You can just intervene in providing stability to the midsection and coordination and integration with the lower body. That's all, and upper body. That's all you can do. So getting it any more detailed is only serving to create more trouble. Do you have suggestions for hamstrings like stretching, etc.? Generally speaking, Secret Team, you're going to be working on those hamstrings as you go through, like the hip hinges, for example. We do in the core relief work for the program. People are doing a hamstring stretch. Like, you should do that, but you need to know how to do it, right? And a lot of people struggle with the hip hinge. So if you can't effectively perform a hip hinge, right, you struggle with that and making that hip hinging motion natural and normal, then you're going to struggle with the hamstring stretch, because the hamstring stretch is not going to be a hip hinge. Your hamstring stretch is going to be around in the lower back, and that's a problem. So you need to learn these things pretty swiftly. So a lot of people, they struggle with that. They really do. But the hamstring stretching is part of the process, but it's part of the relief work. And we understand very clearly that although we're doing that hamstring stretching with a neutral spine, it's going to be temporary in its effectiveness. It might be temporary for 5 minutes. It might be temporary for 15 minutes. As you go through the process of rebuilding strength and stability into the spine, the relief will last longer. The effects will last longer. And then one of the nice things to do, for those of you that are further on in the recovery process, I saw something not very recently, it was maybe in the last couple of months, talking about stretching versus strengthening, and for the purpose of stretching, right? So it was saying, if we just do hamstring stretches, what kind of flexibility improvements do we get? Versus if we did like a hip hinge or an RDL, Romanian deadlift, and worked the range of motion, what kind of flexibility improvements would we get specifically in the hamstrings? And it was like, there's no difference. So one could make the case that actually just continually doing hip hinges, for example, either with a little bit more weight on a loading day or a little bit less weight on a technique and range of motion day, could be a very nice way of building flexibility and strength in the hamstrings at the same time. Something to think about. I know certainly for like those of you that are a bit stronger or have a history of working out, maybe that avenue is going to be a little bit more effective for you, because you actually find that using the weight helps you get a better stretch. Can you make a video on the upper back stronger? I mean, we've got a lot of videos that kind of talk about that as you go through the process of the program. So we kind of already got those, I would suggest. User 494. Guys, I'm going to get to wrap it up pretty swiftly now. Guys, if you need any more help, that's the hour. Hopefully it's been helpful for you guys. I do hope it has been helpful. If you guys need any more help, any more support, on TikTok, check out the link in the profile page. Make sure you're following. I did do a little story today to let you guys know I was going live at 12. Those of you on YouTube, make sure you're following, subscribe to the channel. You've got notifications turned on. If you're watching this after the fact, you can always post down in the comments. We do read and reply to those afterwards as well. If you need more support, check out the website. That's going to be the best place for you guys to get support. If you've been struggling with back pain, sciatica, herniated discs, you've been from pillar to post, the program has the structure there to help you guys get better and support as well along the way. So I would strongly suggest checking that out. And thanks for joining, guys. Thank you on TikTok and YouTube. Oscar, I've seen you've just posted something there. Let me have a look at that. I did step-ups, hip hinge, and low squat. Do you think the combination of the routine is good? Oscar, check out the workouts in the new program, and I would just follow those. That would be the best route. We've also got a bunch of workouts that are going to be rolling out at the end of this month, September, which will feed in quite nicely with your workouts. But Oscar, I would just go and do the live workouts in phase 4. If you're at phase 4, the new phase 4, this I'm talking about, that we just released the week before last. That'd be the best thing to do. Leo, have a nice day too. Thank you. Secret team headed to the beach. Lucky you, lucky you. Have a great day too. Guys, thanks for joining on YouTube. See you next time.